Good morning, good afternoon, good evening, and good night, friends and colleagues from across the world. Today we have a very special treat for you as to our first podinar with the world-famous Dr. Sam Lee. Thank you so much for your time and contribution to join us today, Dr. Lee.
Thank you, Kioner, for a kind invitation.
This is an exciting topic for many of our colleagues, particularly bone augmentation for implants and sinus lifts that you're an expert for. If I may take a minute, Dr. Lee, and introduce you to the audience. For those that don't know you, they're aware of your credentials and what you have done for the profession and industry and doctors across the world. Dr. Sam Lee is an esteemed dentist in the global community. He's an innovator with a passion for teaching and developing new technologies. As among many other distinguished achievements, he has trained over 10,000 dentists worldwide in implant dentistry, developed new methods for dental x-rays, and designed advancements to surgical tools. He travels internationally, lecturing on a sinus technique and TATs to surgical specialists, general dentists, and dental schools. He's a diplomate of the American Board of Oral Implantology, Implant Dentistry, and is also a diplomate of the International Academy of Dental Implantology. He actively conducts research and developments while running a busy practice in Boston, Massachusetts, and San Diego, California. I've known Dr. Lee for close to a decade, and frankly, I don't know how he takes the time. I think I do a lot, but between all of the innovations and the practice and so on, it's amazing. It's actually very inspiring and motivating. Dr. Lee obtained 2 doctorate degrees, Doctor of Medical Science and specialty degree in periodontology from Harvard University, as well as his doctorate of dental surgery from UCLA, 2 of very well-known universities in the United States. He has won the first place Table Clinic Presentation Award at many prestigious conferences and organizations. 2018 Academy of the AID that you guys are aware of, American Orthodontic Society, AOS, in 2007 in International Congress of Oral Implantologists. He invented the crystal window sinus grafting technique, which we'll hear about a little bit today, and owns the patent on various sinus and surgical instruments. He also introduced a new method of dental radiography that uses ultra-low dosage radiation and allows for angulation correction, enhancing 3D imaging capabilities. I remember him working on it years ago, but I hadn't followed up on him, and apparently the project is complete. As a founder and director of the National Academy doing research, his long-term goal is to establish a dental university in San Diego, where he resides now. He's offering 1-year orthodontic fellowship programs, listen very carefully, ortho, and 1-year periodontic fellowship programs to all general dentists and specialists. And if that's not enough, he has 3 children, 2 wonderful boys, 15 and 10, and a girl at 14. I have a girl and a boy myself. I know how much work that is, and is married to his wonderful wife that I personally met in San Diego, Grace. And last but not least, he was recently invited and elected as a regent of the American Academy of Oral Surgery, which all of our friends behind the scene currently watching are operating. And wow, doctor, okay, let's get started. We have had over 140 world-leading clinicians on the show, but your credentials continue to amaze me because you have hit every single aspect of the academic, the family, everything that you can do as a human being to help others. What's your motivation, doctor?
Just trying to help people and trying to do what you love. That's the motivation.
It's very impressive. So the end goal is the university in San Diego. What is the sort of obstacle that you're facing to get there? Is it regulatory? Is it
yeah, regulatory is the most difficult part, but also monetary funding is also the most difficult part to set up a university.
For all you guys listening in that might be interested in working with Dr. Sam Lee and establishing a university in San Diego, please reach him directly. He will put his information up at the end of this discussion. I remember also, Doc, you used to travel a lot to China, Korea, Europe, Latin America, holding conferences. Are you still planning to continue that post-COVID, or are you going digital like everybody else?
We don't know how the future will unfold, but I love traveling. I love meeting new doctors all over the world. I'm hoping that we can continue to do so, but nobody knows the future, so we just have to pray about that.
So what's the training facility? I've been to your training facility, a gorgeous facility in San Diego that you built from scratch, that not only you practice there, but also you bring patients and lots of doctors on the weekends you have had. And a lecture hall as well. What are you doing with that facility now that, well, COVID is starting to come down? Are you doing courses there now again, or what is the plan there?
Yeah, we still do courses. Yesterday, we had a one-year periodontic fellowship program. People are still traveling from overseas and from other states to come to San Diego, but we do keep a distance of 6 feet apart, and we do try to prevent each other from contaminating with possible virus.
Sure, sure. Totally understand. So kind of like the airplanes, one seat off, one seat on type scenario, and you're still doing your lectures in front of the crew and they get some hands-on and all of that?
Yep. We do have, people still need implants even during COVID. And we have a nonprofit clinic in San Diego where we do implants for almost free. And so we have a huge demand of patients, and my fellow students, they will come into our San Diego facility to learn and to help patients get their smiles that they deserve.
That's wonderful. I was very impressed by your facility when showing up. So you've invented some things. Can you tell us a little bit? What I'm mostly interested in is the sinus lift. You have invented so many things, tools, instruments, techniques in the sinus space. And I just probably overestimated, but half of our patients that come in for implants on the top have some sort of sinus pneumatization, and you're left with very little choices. What is so different? How do you do it different? Because I've seen so many techniques with water pressure and vertical fracturing. And what's so specifically different about the system you have built that is less intrusive?
Yeah, we have to make the sinus technique as easy as possible for the surgeons to achieve success. And I made 7 different versions of Sinus Lift throughout my career. First version beginning all the way in 2007. But I don't believe in blind technique, but I do believe in cresto approach. So my technique is unique in that it's a cresto approach, but it's not a blind technique. That way we can have very predictable result. And it's very user-friendly. It's not something that you can invent overnight. I mean, it took me 13 years of 7 different versions of Sinus Kit, but today I can pretty much say with confidence that we have mastered the sinus lift techniques.
Yes, and I've seen a couple of them. They're very intriguing. Is that something you teach in your perio fellowship, or is it something that you have a specific course on that people can take?
Yeah, we have a specific course on sinus lift, but in the perio course, we do cover sinus lift for 2 days.
So, dear colleagues, you know very well, I know you're out there and you're frustrated with all of the flare-ups in the sinus and the good old Flonase and the prednisone and all the stuff that you have to prescribe from time to time because you infringe up on that space. Although you do things guided, it would be really nice to master sinus lifting. It will tremendously increase your potential in your practice and your bottom line, and you will be able to help a lot more patients. So Dr. Sam Lee, a total expert on the topic, years and years of background. So if you have younger guys wanting to get in, doc. You have 1/3 of the U.S. population missing at least one tooth. It's a tremendous professional advancement opportunity to get into the implant business. What would you tell them? Where would they start? There's so many programs. There's so many people that are just showing good cases. People want complications. People want to learn. In dental school, they taught us, central incisor, lateral incisor, canine. You do the endos, and then you go to premolar and the molars. What would you tell a younger guy that just gets out of school and wants to advance? They don't want to do denture adjustments all their career and fillings. They want to get into implants or something exciting. What do you tell them? Where do they start?
Yeah, education is the greatest investment, as you all know. And nowadays, we have so many good information all over the internet. YouTube has tremendous amount of great information, but you do have to filter your information, and having a mentor is very, very important. People who have experience can guide you to the right path. So I want all the young doctors to get exposed to all the knowledge in YouTube, be open-minded, but at the same time, I want them to have a mentor where they can filter the right information so that they can help their patients achieve the smiles that they deserve.
Lovely.
So having a mentor and just being open-minded, learn everything as you can, but at the same time, having a great mentor will be very, very important.
So select one good mentor and stick with that mentor, because there's also differences in philosophies, as you know, Dr. Lee. And we all arrive at the same standard of care at the end. We need to, but there are different philosophies of how we get there, and it's a cause for contention at times between leaders of industry. So for the younger guys, or the ones that want to expand their clinical practice, find a mentor, a good mentor. I highly recommend myself, Dr. Lee. I've taken a lot of his information and I've implemented it in my practice over the years. He's way ahead of his time. So Dr. Lee, today, a huge topic, bone grafting. So much controversy about, for example, I was in Korea a couple of months ago, and there was a gentleman that was talking about if you put PRP up in the sinus or PRF or whatever technique is being put in, it's fibrous tissue. It's not really bone. Some other school of thought is, yeah, that is bone. It looks like bone on the CT scan. When we do histology, it's bone. So there's a lot of differences coming out of these leaders. So maybe you can give us a perspective on what is real bone grafting and what's not. And I think a lot of our colleagues will benefit from that. What is your thought on this topic?
Absolutely. Yeah, I'll be happy to share my experience. Just because we have radio opacity in the X-ray doesn't mean that it's a true bone. And you're right. And we have to be able to have a long-term data to know that this bone that we have developed is good enough to have implant loading. And only way to do that is to have a long-term data. So we should be open-minded. At the same time, we should be able to listen to the mentors that have a long-term data.
Wonderful. That I agree with. It's very I haven't seen much histological study, but that would be interesting to see, because sometimes they're also biased from the companies that support them, and we never really know. But that would be an interesting study to see actually what happens in there, because I assume sometimes it is real bone and sometimes it is real fibrous tissue. But with that said, I think Dr. Lee has a lot more to offer in this space than I can. You have the floor, doctor, to begin this wonderful presentation pertaining to the secrets of bone grafting, and we will catch back up in 30 to 45 minutes for some questions, or even more. Take your time, doctor. Thank you so much.
Thank you, Killer. Hello, everyone. It's my honor to be here to share my experience about bone grafting for dental implants. And as Keonor mentioned, I run academy in San Diego. And if you guys are coming to San Diego, I recommend you to visit me. We welcome any dentist all over the world. And we also have a nonprofit clinic called Care to Share Smile. And we have a 13 operatory nonprofit clinic in San Diego. In addition, we go all over the world to provide free treatment to many underserved population. And if you guys want to join us, we welcome you to join us, and you will have fantastic time helping many people who need a lot of dentistry, but they cannot afford. And I've been very blessed to meet many dentist professionals who are willing to donate their time to help all these people. At the same time, we have surgical program in our clinic where we teach dentists to become very proficient in surgery, not only sinus lift, but also periodontics and also orthodontics as well. So we have many programs in China, in San Diego, California, in Mexico, in Ukraine, and in Chile, South America. And it's been a phenomenal experience for me as a dentist to meet many great clinicians all over the world. And we also offer a one-year fellowship program, and people can really push their limit in terms of getting education. And we also have many extensive video library about treatment planning and periodontics and orthodontics in our website, continuingeducationfordentists.com, C for dentists. So today I wanted to share with you how to build bone in easy manner. How can we use minimally invasive technique to build bone? And over the years, I made a lot of mistakes, and I do not want young doctors to repeat the same mistake. It's always wise to learn from your mentors, and today I'm very honored to share my experience in how to build bone in very easy manner. So let me show you a case where a young lady came to my office and she said, Dr. Lee, I need to have 3 implants and you're my number 5 consultation. Obviously for her, money was an issue because then why would she have multiple consultation trying to find the cheapest price? So many dentists told her she's going to need 3 implants, and this is the intraoral photo of her case. And yes, you could debate whether you can save tooth number 3 and number 30 with crown lengthening and root canal, but it was pretty much consensus that she needed 3 implants and 4 wisdom teeth extraction. Now, the price varied from anywhere from $5,000 to $20,000 for her treatment plan. But as a dentist, we shouldn't be too comfortable giving the same treatment plan to the patient. In fact, in my opinion, she does not need any dental implants. Again, I told the patient, you do not need any dental implants. Why? Because for young patients, especially she was in early 20s, and having a dental implant could be a disaster. I do place a lot of implants, but natural teeth are way better than dental implants. And as you can see, by using simple orthodontic technique and taking out the hopeless tooth and mesializing the second molar into the first molar side, now the third molar automatically comes in to the second molar side, and patient no longer needs to have any dental implants. So as you can see here, we have to always look at the patient from different angle and try to see how we can help this patient. And a lot of times, my goal is to prevent giving a patient a surgical technique. And if I am going to employ a surgical technique, I always want to uh, deliver minimally invasive technique. When I was young, when I was young clinician, I love doing ridge splitting. And if you Google my name in YouTube, you will see a lot of ridge splitting, bone block techniques that I put it on YouTube for other clinicians to learn. But as I age and I gain more experience, um, minimally invasive technique is the way to go. And nowadays, we only teach minimally invasive technique. And I think the best implant technique is not to do any dental implants. In fact, almost all the dental implant cases are also orthodontic case. This is why in our academy, even though we started with dental implant academy, we focus more on orthodontics because orthodontics is the least minimally invasive way to help patient have a missing tooth. For example, here we have tooth number 12 and 13. In America, we have a little bit different tooth numbering system compared to other countries. Here we're missing two bicuspid, upper bicuspid. And yes, can you put an implant on first bicuspid? Answer is yes. You could do GBR technique, ridge splitting, you can do bone block, you can do many cool surgical technique. But I believe that instead of doing a GBR technique like here or ridge splitting or any other type of a surgical technique, patient will have morbidity, they will have swelling and pain. And whenever you do a surgical technique, you may gain hard tissue, but you're going to lose the soft tissue. And at the second stage, we have to do apically repositioning and free gingival graft. Otherwise, all the bone that you created disappears because the mucosa tissue will act as a rubber band, pulling away the grafted bone. Therefore, what I recommend is don't take out any teeth. For example, here we have a second bicuspid that is broken down, severely decayed. It needs to be extracted, but do not extract it yet. Use the hopeless tooth and move it orthodontically so that you can gain bone buccolingually. But at the same time, this is the only technique that I know that we can build gum at the same time. Now, I'm a periodontist, but doing a surgical approach to build gum is very difficult and very painful for the patient. Instead, why not use orthodontic technique to gain bone and the gum at the same time? And this is a phenomenal technique that you can utilize. Also, this patient came in for tooth number 89, the front tooth. It was very mobile, very ugly, and she said, I like to have a dental implant. But as you can see here, she has severe bone loss on the radiograph, and this is a disaster. As soon as you take the tooth out, even though she doesn't have much recession, as soon as we take the tooth out, there is no more support from the tooth, and she will end up with huge vertical bone loss. Now, she's 45 years old. She's still not married. Unless you want to marry this patient, you better take this case more carefully because you will end up with huge vertical bone loss if you just take the tooth out. So instead of doing a huge vertical augmentation, better method to approach this is to use orthodontics to slowly extrude the teeth. That way we can not only build the bone vertically, but at the same time, we can build gingiva vertically as well. So when you are dealing with aesthetic zone, always try to use orthodontics to extrude the teeth and then build the bone vertically. And I have referred this case to my colleague to make the crown. Now, orthodontic is beyond just making the bone or making the teeth straight. Traditional orthodontic, we were trapped in dogma and just thinking about the torque of the incisors and the smile line. But because we have a mini screw, now we can go beyond what we were able to achieve. Now, when I see my patient, I don't look at the E line or I don't look at the traditional orthodontic anymore because of the recent advancement in surgical technique, we can move the maxilla in any position we want. So first, I want to set the maxilla. If patient comes in with occlusal cant, as you can see here, by putting a mini screw, we can intrude the whole arch. We can correct the roll of a whole arch. We can correct the yaw, and we can correct the pitch of patient's maxilla. Then we position the mandible in the stable TMJ position. So there has been a lot of advancement in orthodontic field, and I suggest young doctors to really be open-minded instead of being trapped in old dogma. Now, look at this patient. Patient lost a bracket on tooth number 9, but she was traveling overseas. She lives in Orange County, California, when I saw this patient, but she had to go to see her parents for 2 months, and she lost the front tooth bracket. So I told her simply, just come back, just go to local dentist, take out the bracket so you don't swallow, come back 2 months later, and we'll put the bracket back. And can you see a mini screw that I placed in bicuspid region? This tiny implant called temporary anchorage device is so powerful that it actually intruded the whole maxillary arch. Now, this is way more powerful than left forward surgery, because left forward surgery, you have a great risk in surgical problem. But with this small, tiny orthodontic implant, ladies and gentlemen, we can move not only a single tooth, but whole maxilla at a time. And you can see the number 9 didn't move because this is a control, right? She lost the bracket for 2 months, and you could see a big difference in 2 months, how much we can correct patients' occlusal cant just by using temporary anchorage device. So when orthodontic patient comes in, we look at their shoulder. You can see compared to her nose, she has a severe occlusal cant. First thing we do is we level the maxilla. Then the mandible comes in automatically to more stable position, and really we can help many patients achieve their great smile, correcting occlusal cant, really distalizing the whole maxilla back if needed. If they have a small nose and small chin, we distalize the whole maxilla. If they have a big nose and big chin, then we procline the maxilla. Not only a single tooth by just moving the torque, but we are moving the whole maxilla forward to really improve their facial profile. So again, as you can see, this patient came in for implant tooth number 6, which is the upper right canine, and he's congenitally missing that tooth. But patient has a severe occlusal cant. Now, in today, digital dentistry has really changed the way how I practice. With digital dentistry, we can offer so much more than we used to. Even 5 years ago, I used to take a face bow and mount them in articulator. We don't do that anymore. We use digital scan, and we take our digital information into a digital articulator, and we can really help our patients go beyond what we were able to do. So notice this occlusal cant and see how powerful this screw is. And it takes literally about 5 seconds to put them in. I'm just going to skip the surgical video because we don't have a lot of time. But after 5 seconds of a simple surgery, we can intrude the whole arch with this tiny screw. This is only 1.6 millimeter in diameter, 8 millimeter in length, but it is so powerful, it can correct occlusal cant. And as you can see, after 2-3 months, patients end up with open bite here because now we have, from the beginning, we have intruded the whole arch. Then after we correct the maxillary cant, then we will go ahead and start the implant treatment planning. So how do we do implant treatment planning nowadays? We use only digital dentistry, and it's kind of debatable which angulation we should place an implant on number 6, which is a canine. A lot of clinicians are still practicing biological driven implant dentistry where we tend to place implant where the bone is, right? So the correct implant placement is where the implant exits on the cingulum. So when you do place implant in correct prosthetic position, your implant will be outside of bony housing. But today, I'm very honored to share with you a simple tunneling technique where you can augment any bone and you can build any amount of bone with simple tunneling technique. So as you can see here, in order to place implant on correct cingulum position on canine, we do not have enough bone. So yes, you have an option. You can place the implant where the bone is, but you will end up with a bone loss and not a good long-term outcome because you have a cantilever. If you use 25-degree abutment, when patients bite down, you're not going to have a good outcome. So I'm just going to skip the surgical video really, really quick here. But the key point here is that in order to have a great outcome, we need to use patient's stem cell. Let me go back here. And this is a tuberosity stem cell that we harvest. And I will share with you later on because my video is having some problem here. But instead of laying a flap to do any bone graft, we make a very, very tiny incision. And every surgery nowadays is done without any flap. We just make a small vertical incision in the mucosa. Then we will utilize patient's tuberosity blood. And this is very, very powerful because this tuberosity blood has all the stem cells that we need. And this tuberosity blood is so sticky that when it binds FTBA, and I only recommend cortical bone, and for various reasons. You want good osteoconductivity from your bone graft, then I only recommend FTBA, which is a cortical powder. I do not recommend cortical cancellous. It has too many porosity, and we only recommend cortical powder mixed with stem cell. So after we tunnel the site, now compared to before, compared to block bone or rigid splitting, this surgery, ladies and gentlemen, takes less than 5 minutes. No surgeries takes more than 5 minutes in our clinic because everything is done through a tunneling technique. And when you do tunneling techniques, ladies and gentlemen, there isn't too much suturing and there's no morbidity. I mean, I recommend patients to go back to work on the same day because this is very minimally invasive technique that we employ, and patients are very, very happy. Now, as I mentioned, because of the mini screw, we're not too much focused on making class 1 canine, class 1 molar anymore. That's the old days. Nowadays, we focus more on face, we focus more on airway, and as you can see, when you have retrognathic mandible, we bring the mandibular jaw forward using the TADS, and by doing so, you can really help the patients improve their airway. And as you can see here, even in class 3, we will place 2 TADs on the chin, and we were able to jump the bite, bring the maxilla forward immediately without placing any brackets on the lower jaw. And not only do we improve their airway, but we are improving their profile. And dentistry become very, very exciting when you start to understand bigger scope, and when you start to move the whole maxilla front and back. Your TMJ becomes more stable because now a joint has more space. We used to shove the mandible back in class 3 cases, but now because we can bring the maxilla forward non-surgically, we can really help the patients achieve proper TMJ profile and stability in joint and also in their facial profile as well. In other hand, when this patient has a small nose and small chin, on your left, patient wants to push their mouth more distally. How do we do that? We use the TAD, and you can see that we can improve patient's face dramatically by utilizing this technique. Now, I want young doctors to understand that orthodontics is not just about making class 1 occlusion. Orthodontic is about improving the face. If you have more teeth, you have more lower lip support. If you have less teeth, you have less lower lip support. Let's look at this patient. She came in with asymmetrical jaw, and she came in with recession on tooth number 9. You can see the recession, not only the recession, but you could see her midline is shifted to her right by about 4 millimeter. Why? Because she just finished orthodontic by a very old orthodontist who only knows about class 1 canine and class 1 molar relationship. I think he did a phenomenal finish instead of nice class 1 canine and class 1 molar. However, he missed a big boat. Look at her face. She's asymmetrical here. And why is she asymmetrical? She was congenitally missing tooth number 5. And orthodontist said, well, my job is to save as many teeth as possible. So he only took out tooth number 29, which is a lower bicuspid, and he finished the case. But when you have asymmetrical number of teeth, right and left side, you will end up with asymmetrical face. So I recommended to take out the other side and continue on with braces. So after I have extracted the other bicuspid, look at the midline. We were able to fix the midline to her nose, and look at the recession on tooth number 9. Tooth number 9 recession has automatically improved by pushing the tooth more distally. The tooth now is inside of bony housing, and the gum grows automatically, ladies and gentlemen. And here, most important is her face. Look at this girl's face. What is more important, 2 bicuspid or symmetrical face and more self-confident? So I want young doctors to understand that there is a lot more than what we learn in dental school. In dental school, what we learn is only 1%. But as we practice, your standard of care will be changed, and depending on what we can do to our patient, we have to really push our limit to learn and be open-minded and see what is really the standard of care for our patient. Now, I like to start with this case here for sinus lift. Here, unfortunately, a patient was referred to me for failing implant. Obviously, you can see upper right implant is 90 degree to where it's supposed to be. And you can also see on the left side, the implant is too deep, right? It's inside of the sinus. I must say that many people who are not very well trained right now are doing so many sinus lift too early in their career. I recommend at least 1 year of training, because if you take weekend courses and you do a sinus lift without proper training, you may get into this type of problem. We have many, many problems like this right now in United States, and it's because many people tend to think that sinus lift is too easy, and they buy some type of sinus kit, or they take a weekend course and they do a sinus lift without completely understanding the bone. Then you may end up with a big problem like this. So almost every 2 weeks, I have a case like this where it's referred to me to remove the implant from the sinus. Unfortunately, when I open a flap, implant is actually inside the sinus, and we have to make a lateral window to put the to take out the implant. Now, this implant can be inside of Schneiderian membrane, or it could be outside of Schneiderian membrane. This is my latest sinus kit that it will help you to get into a sinus membrane without tearing the membrane. And we utilize hydraulic pressure because it will prevent membrane rupturing when we directly are in contact with Schneider membrane, and we will just utilize this at 1000 IPM with the stopper, because sinus wall can be in various thickness. Here in 3 seconds, we have a nice access to our Schneider membrane. Now, I believe in minimally invasive technique. So you can see that sinus window is very, very small. Why? We have what we call critical size defect. If you make a huge sinus wall, yes, it'll be easy for you to do sinus lift. However, that wall, if you follow up for a long time, is never going to heal completely. If you follow up long time, the CT scan will show that it will never heal completely. Therefore, we try to make a very, very small window, about 6 millimeter in diameter, but I rather make multiple windows so that it is smaller than critical size defect so that it can heal automatically. Why 6 millimeter? Ladies and gentlemen, you know when you take a molar out, that is about 12 millimeter hole that we have in our molar side. Why do you think God created septum, interdental bone? Because God knew if you don't have an interdental bone, that socket will never heal. So if you lose that interdental bone, patient will end up with huge defect and it will never be filled automatically. So we have to respect biology, and when we do surgery, we have to respect biology here. Now, as you can see here, I could not find the dental implant, which means it is above the Schneider membrane. Now, I have no option but to tear the membrane here to remove the dental implant. So I decided to, unfortunately, make a perforation and take out the dental implant. How do you take the dental implant out? Use the gravity, have the patient to sit up, then implant will pretty much roll to the lowest point due to gravity, and you could simply take the implant out. Now, when you have a huge perforation, how can you repair this huge perforation? Well, some people talk about using membrane, etc., but you want to use autologous tuberosity stem cell when you are repairing this type of soft tissue. So best way to seal torn Schneider membrane, ladies and gentlemen, is not collagen membrane. It is to use bone marrow aspiration. This has everything. It has osteoprogenitor cells. It has the platelets. It has everything that we need biologically speaking. So how do we do this? I like tuberosity because the bone is very, very soft. So we utilize special syringe to go inside of tuberosity, and you just aspirate about 1 to 2 cc of tuberosity blood, and we mix this with FDBA to have great outcome. So I'm just kind of fast forward here due to limited time here. But as you can see here, in this patient, I have drawn more than 10 cc of tuberosity blood clot, and this is minimally invasive method of drawing tuberosity bone marrow stem cell. Now, because I have a 2 doctoral degree, we decided to do flow cytometry, and I have found many CD34 and 45 cells, which is very, very promising. But clinically speaking, I think this is like a gold medal. We used to be stuck in bronze medal, talking about osteoconductivity, that is using a bone graft, allograft, xenograft, or even alloplast. Then last 10 years, we focus on osteoinductivity, right? Using BMP, PDGF, GEM21, PRP, PRF, I guess could be considered to be osteoinductive as well. But why not go all the way to the gold medal, where we actually use the stem cell to do bone augmentation to our patients? Here, I just used the same blood clot, and when I scored blood clot, this is what happens to the torn Schneider membrane. Look at this. Look at this graph. It has completely concealed. Now I can pack the implant and place the implant pack the bone for the patient without worrying of bone graft going into the sinus. So this is the minimally invasive method. On the other side, we also took out the implant, and then we have done sinus grafting for this patient. Now, even with that huge perforation, ladies and gentlemen, look at the bone graft. It's not going all over the sinus. It's staying together because this tuberosity blood, it is amazing. It is so sticky. It holds everything together. It is very different from PRF and PRP that you guys are used to. Well, PRP, PRF, and all this great stuff, they are great, but it's coming from venous blood. Venous blood, ladies and gentlemen. You want blood from bone marrow. Let's use the common sense. Which one is going to have more osteoprogenitor cell? All the way in the venous or in your jawbone? I rather have a autogenous bone mixed with stem cell from the jawbone rather than going to venous blood. It's just a different place. It's just a different type of stem cell you're going to find. Let me show you another case. Here, patient also presented with oral-anterior communication from previously failed implant location. Now, when you guys place an implant, you guys have to be very, very careful because your implants that you're placing, you're putting your signature into patient's jawbone. Therefore, when you have a failure, look at how much damage we're doing to our patients. Here, patients cannot drink the water. Every time they drink water, it goes to their sinus, to their nose. And when they blow their nose, air is coming into their oral cavity. So how can we fix this type of defect? Again, minimal palatal incision is done. We already have a perforation when we got there, but I can fix this perforation very easily with tuberosity clot. And by using tuberosity clot, as you can see here, now membrane moves up and down. And as you can see here, membrane moves up and down. And now I feel comfortable packing bone. After we pack bone, ladies and gentlemen, we are going to place an implant. Remember, there was 0 millimeter of bone because there was oral-anterior communication. But if you know the diameter of the hole very well, as you can see here, we can even place the implant with more than 50 newtons per centimeter if you know your osteotomy very, very well. In fact, when patient has no bone, you end up with much denser bone. Because the bone is much, much thinner, God will create much denser bone. And when you have a very dense bone, you can stabilize the implant with excellent initial stability. So this is an immediate post-operative x-ray. And when you're doing sinus lift, ladies and gentlemen, it is very, very important to pack the bone densely. If your bone is not dense and there is a lot of gap between bone graft by using, for example, cancellous bone, that's the worst thing you can do because it has so many porosity, you're going to have so many soft tissue between bone. If you're going to choose a bone graft, I recommend 200 to 800 micron of cortical bone powder, and that is the secret of bone grafting technique because we want good osteoprogenitor cell when you are doing a bone grafting technique. Now, can you see the old buccal plate here? And can you see the new bone graft that I placed here? We did a buccal augmentation and we placed a nice sinus lift here. And you always want to over augment when you're doing a sinus lift because it tends to shrink a lot. Then after 6 months, this is what you should look at. Dr. Shah asked me, how do we know if the bone graft that you added is a true bone or false bone? Yes, you could take a biopsy, but in clinical practice, ladies and gentlemen, you're not going to take a biopsy for the patient. In fact, there is a better method to know if this bone graft is a true bone or not. How do you know? You see this old graft? Can you guys see my mouse? On the left side, there is a clear evidence of old cortical bone. The old cortical bone disappears. You see how the old cortical bone disappear here? If the old cortical bone disappears and new cortical bone forms on the outer layer, this is a true morphology of new bone formation. So you don't need a biopsy. You just need to look at the new cortical bone formation and disappearance of old cortical bone. Then that is the true morphology of bone grafting bone grafting outcome. So what I recommend here is, I apologize, my kid left the phone here. I didn't know the phone was here. What I recommend here is when you are laying a flap, it is very important to preserve periosteum. This is where the basics of surgery comes in. And I can tell you, many people come to my surgical course, and even 20 years experienced oral surgeons will make this mistake. When they are opening the flap, they are tearing the periosteum. When you are opening the flap, you have to preserve the periosteum, because periosteum is everything, ladies and gentlemen. When you have the periosteum, this is the best membrane that God has given to us. In fact, if you are using collagen membrane or titanium mesh or any type of other type of membrane, you are actually blocking the blood supply. And if you are using membrane, you will see that your failure rate is much higher. You can have membrane exposure, you can have wound dehiscence. Why? Because you are simply blocking blood supply. Surgery is all about blood supply, and it should begin with flap elevation. Whether you are doing tunneling or whether you are doing GBR technique, whether you are doing bone block technique, same concept applies. You have to preserve this periosteum. That's why basic periosurgical technique is very important. And I always recommend my students to take at least 1 year continuum rather than taking weekend classes, because surgery is a serious stuff. Every time you make a mistake, and every time you put a wrong angulated implant, that patient is going to walk around with your signature, and you will have a bad reputation. And when we are placing implants, we always recommend guided surgery so that we can always have a beautiful result. And in 2020, digital dentistry is the key. I have placed more than 10,000 implants free-handed, but still I use guided surgery for every single case, because that is the standard of care. In 2020, ladies and gentlemen, the standard of care is guided surgery. So as you can see here, there are various sinus technique, and I'm kind of running out of time, so I will make this long story short. Our teachers have taught us that when you have more than 5 millimeter bone, we are supposed to do crest approach. When you have less than 5 millimeter bone, we are supposed to do lateral approach. However, this is a very old concept. This was recommended when panoramic X-ray was standard of care. In 2020, CT scan is the standard of care. I mean, I think it's almost a malpractice to do implant dentistry without CT scan. With CT scan, we're able to see three-dimensional aspect of the bone, and buccolingual dimension is way more important than vertical bone height. If you have wide bone, why do patients have wide bone, ladies and gentlemen? God gives you wide bone because the patient is brachyfacial, their masseter is strong, their temporalis is strong. If you place small, tiny implants, even 4.0 implant in brachyfacial wide jaw, you're going to fail long term. If patient present with wide bone, God is telling you, please place wide implant. In contrary, if patient present with narrow bone, they have weak muscle, they have weak masseter, they have weak temporalis, they are dolichofacial, and God is telling you, this patient needs narrow implant. So you're not going to place 5 millimeter diameter implant in patients with long face, weak muscle. So you have to look at buccolingual dimension, and you have to access what is the muscular forward for this patient and place the correct implant for this patient. So when you are doing extraction, why even open a flap? Lift the sinus through the crest. Patient already has an opening. Patient already has an extraction site. So why don't you do a sinus lift through the socket, which is not a blind technique. As you can see in this photo and the video, this is the easiest and the fastest way to do a sinus lift and place implant at the same time. Now, if you want to do lateral technique, yes, you could do lateral technique, but why? In 2018, I don't do this anymore. But if you watch my 10 years old video, I have a sinus kit where we pop open the lateral wall just like opening a Coca-Cola can. It is very easy to do a lateral wall using this technique. But in 2020, only time I will go to a lateral wall, ladies and gentlemen, is to take the implant out. When my colleagues have made a mistake and pushed the implant into the sinus, that is the only time I do a lateral window, because crestal window is very, very predictable. So in 2009, I developed this can opener concept where we open the sinus through a very easy technique. But in 2020, we have improved our technique way more, and I want to introduce the iPhone 11 of sinus lift technique. Now, sinus lift technique is all about preserving the Schneiderian membrane. However, Schneiderian membrane and the sinus floor is never flat. Sinus is never flat. Even though X-ray shows that it's flat, it is not. Buccolingually, it may be in inclined plane. So most difficult case for sinus is when you have a sinus in inclined plane. So with this hydraulic pressure, as soon as we go through the sinus floor, this hydraulic pressure will lift the membrane for you automatically. So you are doing two procedures in one instrument. Again, inclined plane is most difficult. And by using this hydraulic pressure, after we immediately penetrate the sinus floor, we can elevate the Schneiderian membrane. So here, I have a case here where I'm demonstrating the sinus floor is at 45 degrees. That is the most difficult. Again, when the bone is flat, you can even use osteotomy to lift the sinus. But when the sinus is at 45 degrees, you need irrigation, you need a hydraulic pressure, not 90 degrees, but coming at 45 degrees so that it can protect the membrane by going through 45 degrees. You can have 100% guarantee result when you are doing internal sinus lift technique. After you go through the Schneiderian membrane, you can inject bone and place implant at the same time. Now in here, I'm just going to push the limit. I'm going to actually try to tear the membrane. But as you can see here, even in 1000 RPM, 2 millimeter beyond, it is virtually impossible to tear the membrane with this technique. Therefore, sinus lift is very, very predictable, but not every patient is able to receive sinus lift. What do I mean by that? Sinus lift is all about natural ostium. If the ostium is narrow and if the sinus is diseased, doesn't matter what you do, you're not going to get good result. Therefore, diagnosis is the key. And in our one-year fellowship program, we don't teach people how to do sinus lift technique unless you have the basic understanding of your surgical technique. Worst thing you can do is you do a sinus lift, but this bone is just floating inside the sinus because it has not turned over to a new host bone. So this type of case is the most challenging because here we have inclined plane. We have a huge drop in my implant site. Is almost 90 degrees to my implant site. Again, when the sinus is flat, that is easy. Anybody can do it. you could do it even with osteotome technique. But when the sinus is vertical like this, that makes the case very, very difficult. When you're doing sinus lift, I want you guys to always make a palatal incision, and then I want you guys to utilize the correct technique so that you have nice optimal outcome, so that patient can be happy and you can really only perform minimally invasive procedure to your patient. This patient was able to even take a flight to Africa right after her surgery. Dr. Shah, how are we doing on time? I think I have a lot more to share with you. I think you will find a lot of interesting surgical video on YouTube. I love YouTube platform because there are so many good information and they are free. I want you guys to be open-minded, go outside of your box so that you can learn more what is available to us so that we can help more patients achieve their smile of their dream. Thank you very much.
Wow, Dr. Sam Lee, I was so into the presentation that I kind of lost track time myself.
I cannot hear you.
Oh, hang on.
Dr. Shah, we cannot hear you.
Can you hear me now? Can you hear me now? Can you hear me? Okay. Can you hear me?
Oh, now I can hear you.
My apologies.
I can hear you now. Sorry.
A little technical difficulty. I was so mesmerized into your presentation that I lost track of time and my audio apparently as well. Dr. Lee, that was an amazing presentation. Let's get down to some questions here. You have answered a lot of these things that I encounter clinically all the time. What is the rate of resorption from the clot from tuberosity?
Rate of resorption, like shrinkage?
Yes.
So tuberosity is just the blood. You could think of it as injectable PRP or PRF. It's just the liquid. So I recommend to use what we call FDBA, freeze dry bone. And FDBA can come in as a cortical bone, or it could come in as a cortical powder, a cortical cancellous, or it could come in as a cancellous bone. But when you mix the cortical powder with tuberosity blood, and depending on how densely you massage the flap, your rate of shrinkage will be different. What I recommend is try to condense as much as possible so that you get minimal shrinkage. After your surgery, it is very, very important to really massage the surgical area. So after you suture, you push on the graft material and you're condensing this as hard as you can. But remember, because we are using cortical powder, there is not going to be a huge amount of shrinkage. If you use cortical cancellous, or worst of all, if you use DFTBA, you're going to get about 30% shrinkage.
What gauge are you using? What gauge of a needle are you using to get to the debosity? I know you're using a special needle.
It's a 20 gauge, and it has to come in with very, very special metal so that it doesn't get bent. So there are many brands out there, but you have to use a special needle with 316 medical grade needle so that it doesn't get bent when you penetrate the tuberosity. Now, most patients have a very soft tuberosity, most patients. So you may be able to do it for most patients, but in some patients, especially dentate patients, for example, if they have a tooth on the second molar, then the bone density tends to be much, much harder. Then you will need a special medical grade needle to penetrate.
You're right. You got D5 bone up there. You should be able to penetrate it easily because a lot of times you don't drill even up there. Use hand instruments to make our osteotomy. Doctor, let's get to the sinus area now. Some other companies and groups promote reverse drilling in those areas to prevent Schneiderian membrane from ripping. Do you believe in this concept?
Yes, I think the technique-wise it works. However, when you're condensing the bone, in my hands, I see more bone resorption, especially the crest of bone. So I know exactly what you're talking about. I don't want to mention like a company name, but in my case, I do not use because of the crest of bone loss, right? Now, crest of bone is very, very sensitive. Crest of bone has hard virgin canal, so it's very different from medullary bone. Crest of bone is more prone to pressure necrosis. Pressure necrosis happens only in crest of bone, and when you condense the bone too much and you block the hard virgin canals, then you will get crest of bone loss. Medullary bone, yes, you can condense as much as you can. It's not going to cause any cause. So especially for the mandibular surgery, I don't recommend like a reverse drilling, and I don't even recommend placing implant too tight. If you place the implant too tight, then you will see 1 or 2 millimeter bone loss when you take the X-ray 1 month later.
There are some doctors that tell you to essentially undercut your osteotomy and get better preliminary stability, but at the same time, you could end up with a disaster, as you know, with necrosis and that layer of drilling, and especially if you put it under pressure, under compression. That's great stuff. So hydraulics, you're using water. I mean, this is some cutting edge concepts you're presenting here. What is the difference in the technique that you're recommending versus the one that our fellow colleague from Korea, Dr. Seok Son, does with the water as well? Are you familiar with that technique where he lifts it, he puts a little bit bone, he lifts it again with the water, he puts a little bone? I saw from your videos that you mostly directly create that space, get your elasticity, and then you put your bone in.
Yeah, I have a great respect for Dr. Son. I think he's an innovator, but I do not know too much about his technique, so I cannot comment. I'm sorry about that.
No problem. So you guys are the two that I've seen so far with the hydraulics concept. It's very, very interesting. So what do you do when you go in there and the Schneiderian membrane is so hard attached to the bone that the water, have you had an incident where actually it ripped when you were trying to lift it slowly with the water?
Do you mind if I share with the audience one more slide where maybe they will be understand? Is that okay?
Please, absolutely, yes. Could you share that slide and I'll bring it into the stream? So that's something that came to my mind is, okay, sometimes geriatric patients, and maybe you can also respond to this periosteum discussion. What's better, having a periosteum that you flap back over, or is it better to make leading points, as some say? Sorry to put you in a spot on all these questions, but probably a lot of people are thinking similar questions. So I like to kind of get your opinion on it.
Dr. Shah, are you able to see my PowerPoint?
It hasn't come through. We closed it. So you may have to share. There it is. So you have, okay, here, I'm going to bring it back to the stream. I'm going to bow out so you can get to your slide. There you go. Go ahead. You can all see it.
So you could have 3 scenarios when you're doing a crest approach. So you're looking at a small osteotomy through the crest. This is what I call healthy and thin Schneiderian membrane. Can you see my mouse cursor?
Yes.
Okay, so you see this bluish purple area?
Yes.
That is the healthy Schneiderian membrane. And this red area is the bone. Now, keep in mind, as I mentioned, sinus is never flat, right? Sinus always has a maybe higher bone on the buccal or palatal. Of course, mesiodistal will be the lowest point. And therefore, you have some bone chips and you have a Schneiderian membrane. Okay, so this is a healthy sinus. In contrast, this is a typical smoker. You have a thicker Schneiderian membrane, but it's more opaque in color. It's white. Since it's thicker, it's tough, and you can even put a lot of pressure. It's very, very difficult to tear. So this is a thick and somewhat, it is a borderline between chronic sinusitis versus healthy sinus. So by definition, if it's thicker than 3 millimeter, we call this chronic sinusitis. And if the membrane is thick on the apical portion close to the root, then most likely it's coming from the root or molar. But if the thickening is very close to the ostium, then the origin can be from the maxillary sinus. In contrary, on the right side, you have what I call unhealthy sinus. Now, typically, this type of Schneiderian membrane is like 5-6 millimeter in thickness, and it's very obvious on the CT scan. Now, this type of case, we should not do any sinus lift because by the time you start to remove the membrane, there is like a multiple layer of Schneiderian membrane. Maybe it's not even a Schneiderian membrane. It's a whole bunch of inflamed tissue under the Schneiderian membrane. But when you go ahead and scrape those membrane out, you will begin to see the Schneiderian membrane that is similar to thin sinus. So when you are lifting a sinus in unhealthy membrane, there's a chance that still the sinus floor has some residual soft tissue. And those cases are the cases where bone graft, you add a whole bunch of bone graft, but it never integrates with the host because you have never detached the sinus from Schneiderian membrane from the sinus floor. So we have a small instrument called Cobra Instrument, and it is used to go inside the sinus floor and scrape the sinus floor. It is very, very important to manually scrape the sinus floor so that we get a lot of bleeding from the sinus floor. And again, when you have a lot of bleeding, we are going to recruit all the osteoprogenitor cells to build bone. Without bleeding, you're not going to have a good outcome in terms of bone grafting. Now, in unhealthy patients, if you go ahead and graft, you will end up with a lot of problem with sinusitis in their mouth. So you don't want to be grafting on patients with sinusitis.
Doc, that's okay. That's a great scenario. I'm gonna keep the slides up because I got more questions for you. So besides the fact that the technique is good for your healthy Schneiderian membrane, and often when I do sinus lift, I see the membrane actually completely separated from the bone on its own and going up and down as the patient breathes, as you know. So what is your solution when something goes wrong and you perf in there, and that could happen to any of us, and I've seen you show techniques on eggs and others where it doesn't happen, but when it happens, what is your protocol? I've heard Augmentin, prednisone, Flonase, salt water rinses. What is your protocol to correct the complications so we don't have to end up sending our patients to ENTs to do an evacuation?
Yeah, that's an excellent question. So perforation is not a big deal. Even the perforation happens, worst thing that can happen is your bone graft comes out through the ostium, through the nose. So I will tell my patients to, when they're taking shower, I want them to drink the water through their nose so that they can wash the sinus. And you put the patient into Sudafed. Pseudoephedrine is a very, very powerful vasoconstrictor. So in America, I don't know about other countries, but in America, we have Sudafed, regular Sudafed, right, which is ephedrine, and we have long-lasting Sudafed called pseudoephedrine, right? We have phenylephrine and pseudoephedrine. Now, phenylephrine is regular Sudafed, and regular Sudafed is not as good in opening the ostium. Pseudoephedrine, which is what we call Sudafed 12 hours or Sudafed 24 hours, are excellent vasoconstrictor without exerting too much pressure on our heart. You know, our beta receptors, we have them We have them in heart, beta 1 receptors, and we have alpha receptors as well, alpha 1 receptors, which vasoconstrict the blood vessel. And those are the pseudoephedrine. The Sudafed 12 hours will attack mostly in the sinus. However, in order to buy Sudafed 12 hours and Sudafed 24 hours, the long-lasting Sudafed, you must give your driver license in state of California, because many high school students tend to do drugs. They get high with the Sudafed. So government does control, but I recommend this amazing pseudoephedrine when you have a perforation, so that patient can take out the bone. Now, surgically, when you have a perforation, you can manage them by surgically suturing the membrane and lifting the membrane. You can salvage your perforation as well. If patient travel, for example, if patient came from Europe to see me to San Diego, then what I would do is, if I have a perforation, and it can happen, you know, I'm human also, right? So if perforation happened, then I simply bring the patient back 3 days later after injecting tuberosity clot. 3 days later, we have a very, very firm membrane where I can lift the membrane 3 days later, so that we can do a successful augmentation.
Oh, wow. So you go right back at it.
Yeah.
That's impressive. Usually half of our doctors are sitting there praying that all of the sinus cleans out, so they don't have other concerns with the patient. That's wonderful. You go back to the augmentation. Dr. Lee, this was one of the most exciting sessions we have had. While I have you on the line, tens of thousands of people are going to be watching this, and also we had close to 400 shares and watch parties and what have you. So people love you, and I highly recommend that. I'm going to be looking into your fellowships myself, actually. I got pretty excited on this one, especially since you have spent the last 7 years fine-tuning all of these programs and kits and protocols. So I invite all of our colleagues and friends across the world to look into Dr. Sam Lee. He's not very hard to find, and to participate in some of his courses. And we really thank you for, by the way, he donated his time today without selflessly to come and help some doctors. So take that one to heart. Thank you for your time, Dr. Lee. We look forward to having you on a future show.
Thank you. Thank you, Dr. Shah.
Bye-bye.